I have the pleasure of introducing our speaker today. Dr. Kelly S. Ramsey is an internal medicine physician who has treated substance use disorder since 2004. She is board certified in internal medicine and addiction medicine. Dr. Ramsey currently works as the chief of medical services at NYSOASAS. Dr. Ramsey has provided expert advice to the New York State Department of Health AIDS Institute by serving on numerous committees for over a decade. Dr. Ramsey was the recipient of the New York State Department of Health Commissioner's Special Recognition Award for contributions to drug user health in New York State in December of 2018. Dr. Ramsey serves as the HCV and drug user health champion for the Capital District of Mount Sinai to provide educational support for clinical education initiative on HIV, HCV, PEP and PrEP, and drug user health through the New York State Department of Health. Dr. Ramsey is the president for the New York NISAM Board of Directors, and Dr. Ramsey sits on the ASAM National BOD as the Region 1 Director representing New York State. So everyone, welcome Dr. Ramsey.
Thanks so much. Sorry for the acronyms. So the acronyms, I am the Chief Medical Officer for New York State Office of Addiction Services and Supports, which is the single state agency in New York State overseeing the substance use disorder treatment system. And NISAM is the New York chapter of the American Society of Addiction Medicine. So sorry about that. Okay, so I'm going to go ahead and get started. This is a very dense presentation and it will take up the full time. Slides will be shared with you and it's fine for those to be disseminated in whatever way. Slides are public. So I'm going to just start us out and get us going through a very deep dive into xylazine. So first of all, xylazine is known by many names. Some of them are tranq dope, or anestesia de caballo, which means horse anesthesia in Spanish. So our learning objectives today are to discuss an overview of xylazine, its history, its structure, pharmacology, clinical effects, emerging epidemiology, and ethnographic research with individuals using xylazine, discuss its contribution to overdoses, xylazine overdose intervention strategies, and harm reduction strategies for xylazine use, and discuss toxicology testing and drug checking strategies for xylazine, discuss wounds due to xylazine use, and discuss xylazine withdrawal and its management strategies. So first, a history of xylazine. So it is a non-opioid, which is really important when we think about overdose response. It is obviously not going to respond to naloxone because it is not an opioid. So that is why it's important to have alternative strategies. So it is a sedative, anesthetic, muscle relaxant, and analgesic for animals. It was actually originally developed as a potential antihypertensive agent in humans, but was never approved because of severe central nervous system depressant effects. So it is approved in the US by the FDA as a veterinary medication. So it's used for procedural sedation in both small and large animals. So it's not a controlled substance because it is a veterinary medication. And often, and I get asked a lot, well, should it be a controlled substance? I personally think when we control substances and make them less available, they're more likely to then be manufactured illicitly, which is even more unsafe. So that's my 2 cents on that. So when it is combined with opioids, it enables using a lower dose of opioids. So it enhances both sedation and anesthesia. And we'll talk about it more. Why is it being added to the fentanyl supply in just a little bit? So it first appeared in the literature as a substance of misuse in Puerto Rico in the 1990s, and then it became widespread with misuse in Puerto Rico in the early 2000s, showed up stateside in Philadelphia in 2006 when it was being misused. So a little bit more history. This comes from ethnographic research out of Puerto Rico. So this study was actually published in 2012. So data was collected well before then. So it was looking at the prevalence of xylazine use in the previous 30 days, and they found that it was almost 81%. It was a study of almost 90 people who used drugs, and they were recruited from communities around the greater San Juan metropolitan area. So what they found were people using xylazine were more likely to be male, less than 30 years old, living in a rural area and injecting versus inhaling xylazine. They found a high incidence of skin lesions in individuals using xylazine, so just over 35%, and about 28% reported an increase in injection use, and 21% reported at least one overdose episode. The majority of those individuals in the study were using heroin and cocaine together, and about half of them, or just over 42%, used xylazine in combination with heroin and cocaine. And then when they did a study using GCMS technology or drug checking technology, they found that 91% of the syringes containing xylazine also contained heroin and cocaine, and 22% of the individuals who participated in this study did not know that they were using xylazine, but their syringes actually contained xylazine as well. So here's some quotes. These come from Tom, a white male, 35-year-old opioid and methamphetamine injector. So these are some anecdotes on xylazine use. So fentanyl is such a short-lived high that the high, it's a good high, but it's so short that the knot is over real quick and you get sicker faster. See, the tranq extends the high. It gives the dope more of a heroin effect. It's a good rush with heroin-like legs. You could literally drown in a half-inch of water if you did a tranq bag and you fell out. Tranq, it stretches fentanyl out. It's sought after. Certain stamps that are known for tranq have better business. Some people don't like it. I like a good fentanyl tranq bag. You know, a bag got tranq in it because you'll shoot it and you'll get dry mouth right away, and you know you'll taste it. So these pictures are from a DEA seizure in Philadelphia. So these are bottles or packaged xylazine, again, from the veterinary supply. So what is its normal form? So as a veterinary medication, it's sold as a colorless liquid. That has to be converted to a solid, so a bitter tasting solid. It has to be salted into a crystalline substance that then can be dissolved and mixed with other substances. So we suspect, again, we don't know for sure, there is some ethnographic research going on currently with drug dealers in New York City. So hopefully we'll have more information in the next few years. But we think it's added to the fentanyl supply specifically to potentiate the effects of fentanyl to make it last longer. It also acts as a filler because it adds bulk to the substance being sold. So now we'll look at the structure, pharmacology, and the clinical effects. On the right-hand side is showing you the structure of xylazine. It's similar to other medications, such as tricyclic acid medications, etc. So what about its pharmacology and its clinical effects? So it is an alpha-2 adrenergic agonist. So it's similar to medications like clonidine. So what it does is it stimulates the central alpha-2 receptors in the brain. And the effect that this has clinically is it decreases sympathetic nervous system outflow. So what does that mean? It tampons down the fight, flight, or freeze response that we get when faced with a stressful situation. So it causes profound sedation by essentially decreasing the release of norepinephrine and dopamine. So the overall clinical effect of this is to severely sedate someone. And it really doesn't have an effect on the respiratory rate itself like opioids do, but it does affect breathing because remember, it's also a muscle relaxant. So when you are profoundly sedated, and under the effect of xylazine, the tongue itself becomes relaxed, and it essentially obstructs the back of the throat. So in other words, a person won't breathe because they literally have a blocked airway by their relaxed tongue. So by occlusion, it affects the respiratory rate. So as I mentioned, it's similar to other medications such as clonidine. It's a little bit different though, because clonidine also affects blood pressure and it also affects heart rate. And xylazine in and of itself really doesn't do that. So I'm going to have a picture in a minute of the different pathway that it takes from clonidine. So the major thing is this profound sedation and obstruction of the airway. So there are some other effects that people can have acutely under the effect of xylazine. So it also affects glucose levels. So a person will become acutely hyperglycemic or have an elevated glucose level when they're under the effect of xylazine, and then can become hypoglycemic or have a low blood glucose level after the xylazine has worn off. So some of the pharmacokinetics, so it's quick to act. Obviously, that depends on the administration route, but usually the effect is 1 to 2 minutes after initial use. It's very lipophilic, like fentanyl, so it diffuses widely in the tissue and has good bioavailability. The average duration of substance effect is up to 4 hours, but it can last much longer, such as up to 8 to 10 hours. And it can be administered via many routes, including IV, IM, sub-Q, orally, inhalation, insufflation, and ocularly. So here is showing the effect of xylazine on CNS physiology. On the left-hand side is showing the normal physiology, and on the right-hand side is showing the effect of xylazine in the central nervous system. So again, leading to inhibition of norepinephrine and dopamine. So now we'll go through some of the epidemiology around xylazine. So this was a very old article. It was from December of 2001, and it was showing severe intoxication from xylazine inhalation. So in this particular study, this was a pediatric patient who was affected by xylazine. And again, in the literature, you'll see some inconsistencies. So they attributed many different effects to the xylazine. The other thing is that pediatric presentations are a little bit different than adult presentations. So there could be more global effects in a pediatric patient than you'd expect in an adult patient. So in this pediatric patient, they experienced coma, meiosis, apnea, bradycardia, and hypothermia 2 hours after exposure. So obviously, when they gave naloxone, it had no effect because this is not an opioid. And then they needed to support the individual with breathing. So often it requires intubation. If standard oxygen administration isn't effective, it may require intubation or ventilator support. So this is an article looking at xylazine complications in young children who were exposed to opioids that were mixed with xylazine. So this was a case of 3 cases of synthetic opioid intoxication. So they're specifically referring to fentanyl that was complicated by the presence of xylazine in that drug supply. So these kids had severe signs and symptoms, 2 experienced cardiac arrest, and a need for continuous naloxone infusion or multiple naloxone doses. Again, whether that was due to the fentanyl component or they were not thinking polysubstance overdose, so they gave more naloxone than was really necessary for the opioid component is unknown from this short report. And one required a mechanical ventilation for respiratory failure. So again, pretty dramatic presentations in children, but this article is again pointing out to pediatricians that they should be just aware of what is going on in the drug supply and that most exposures are polysubstance exposures. So we do have some anecdotal observations from the field, so from people using drugs around xylazine use. So the first one, as we've talked about on a previous slide, is you can have overdose, but heavy sedation or heavy nod. So it usually comes on quickly. So on average, it's within that first 20 to 30 minutes after someone uses. Many people are completely rendered unconscious from xylazine exposure. So remember that it can last a long time. So somebody can be vulnerable for quite a long period of time. So it's important when doing harm reduction messaging that you're advising people about the risks of using xylazine and being immobilized for many hours. So where are their belongings? Are they securing them so that they're not robbed? That they're in a position so that they're not going to put themselves at risk for some medical complications, which I'll talk about in a moment, but also they could be vulnerable to physical or sexual assault if they are literally unconscious for hours. So if someone doesn't move for many hours, that can cause a variety of physical health complications, including rhabdomyolysis, compartment syndrome, deep vein thrombosis or blood clots, skin breakdown, etc. And then again, remember that there's a complicated effect on breathing from multiple mechanisms of action if someone is using fentanyl and xylazine, and we'll talk about interventions that are appropriate in polysubstance overdoses in a little bit. So again, we see skin ulcerations. So these are not infectious wounds, so they can become secondarily infected by bacteria if someone is picking up a wound or if the wound is not cared for in a hygienic manner. So these wounds can be treated if they're caught early. If they're not caught early, then and not treated appropriately, then unfortunately they can develop into very complicated wounds requiring complicated wound care. I talked about hypoglycemia. So again, after the effect of xylazine wears off, people could be hypoglycemic. So again, a concern, especially with people who might have diabetes. And then there are case reports of anemia. So in the veterinary literature in horses, it does support a side effect of anemia after administration of xylazine. So we do see some case reports of individuals experiencing severe anemia in people who are regularly using xylazine. We think that why that happens is that the xylazine actually binds to the hemoglobin in the bloodstream and causes inefficiency in how oxygen is distributed. So I think, as we all know, that the drug supply, so the unregulated drug supply in the US is becoming increasingly complicated and increasingly more potentially dangerous. So over the last decade, we've seen multiple novel psychoactive substances added to the traditional heroin supply. So we used to see just heroin, then it became heroin and fentanyl, then heroin, fentanyl, and carfentanil, atizolam and heroin, atizolam, and any of the nitazene analogs. Add in flualprazolam, xylazine, brorphine, other high potency novel synthetic opioids. So again, makes it much more complicated to respond to individuals who are actively using. So we're going to go through some epidemiology, primarily from Philadelphia, where we have the most data on xylazine from. So this was looking at the number and percentage of xylazine detections in polysubstance exhibits seized, where the primary substance was fentanyl or heroin. So this is looking in Philadelphia in the time period of 2010 to 2019. And so between 2010 and 2013, there was no xylazine in the seizures. There was 5% in the seizures with xylazine in 2015, 9% in 2017, and 25% in 2019. Oh, I don't know what happened there. Let me go back in. Okay, sorry about that. So this is looking at some drug checking reports looking at novel psychoactive substances, or NPS, in the drug supply in Philadelphia. So again, what people thought they were getting and then what they were actually getting. And what they saw was that in multiple samples, there were multiple substances in the study. Again, it could be they thought they were buying heroin and it was really fentanyl, xylazine, and methamphetamine. So a lot of mixing of substances. This comes from a quarterly report, again, from Philadelphia. This is from the third quarter of 2022. So they looked at about 219 samples in over a 3 or 4 month period. And there were wide spread of purity of the variety of substances. They were primarily samples of tranq dope, so fentanyl, xylazine samples. The average fentanyl purity was about 12%, but there was a wide range. The average xylazine purity was almost 34%, but again, a wide range. Most of the samples that they checked, 91%, contained fentanyl and xylazine, but there were also some synthetic cannabinoids thrown in, as well as counterfeit Xanax and other designer benzodiazepines, and the cocaine purity varied widely. This is looking at a discussion of xylazine on Reddit. So there's a lot of interesting drug conversations that happen on Reddit, and it's often a way to kind of check the pulse on a novel psychoactive substance. So these were mentions of xylazine between the time period of October 2019 and April of 2022. So you can see there was considerable increase in those conversations between about the fall of 2021 and the spring of 2022. This is data from Canada looking at their drug analysis service, and they were looking at counts of xylazine samples and co-occurrence with fentanyl and non-medical or designer benzodiazepines, so synthetic benzodiazepines. So what they found is that xylazine always traveled with fentanyl. So if it were present, fentanyl was also present. But again, there were also some other substances that were added in. So in this particular study, more than anything else, they also saw synthetic benzos or designer benzodiazepines added. So this is looking at xylazine positivity and seized drug testing in the United States. And on the left-hand side is looking at a few states, Kentucky being one of them. So in this time period, so this was looking starting in 2017 to present. So in the number of percent positivity of xylazine in the samples taken from Pennsylvania was about 11% at that period of time. In Maryland, about 9%, Ohio, almost 9%, Vermont, just over 2%. And at that time in Kentucky, it was just found in one sample out of 200 at 0.5%. There's been a lot of studies that have looked for xylazine in a variety of places, including syringes, so taking them from syringe service programs, et cetera. So in the top study on the right-hand side, in a study looking at used syringes in New York City in 2017, they found xylazine in 2.2% of the syringes, and it was most commonly found either in combination with heroin and fentanyl, or heroin and cocaine. And the study below that was looking at the study that I already mentioned that took place in Puerto Rico, where they found xylazine present in over 90% of the used syringes. This is a study looking at used syringes from a syringe exchange program, again, from New York City, and they looked at just over 350 syringes. So what they found that those syringes were positive for typically more than one substance. The majority were positive for greater than one substance. So the most common substances found were heroin, followed by cocaine, followed by fentanyl, followed by methamphetamine, and then fentanyl analogs. The most common adulterants they saw were quinidine, levimazole, caffeine, lidocaine, and phenacetin. At that time in that study, xylazine again was found in 2.2% of the syringes. So this is a health advisory that came out from the New York City Department of Health and Mental Hygiene at the end of December. And this was out of their drug checking program, as well as their medical examiner analysis. I'm just going to read this short quote. So drug checking also indicated the presence of xylazine in the New York City drug supply, a non-opioid veterinary sedative. Xylazine has been identified exclusively in drug samples that also contain fentanyl. Xylazine is a central nervous system depressant that can increase the risk of overdose due to its deeply sedative effect. In New York City in 2021, 19% of opioid-involved overdose deaths also involved xylazine. So this is a super interesting study. This, in contrast to many of the other studies that I've showed you, which came out of medical examiner findings or DEA seizures or studies from used syringes from syringe service programs, this was a study that was done in primary care. So completely different way of looking for how prevalent is xylazine. So they looked in urine toxicology samples between April of 2021 and March of 2022. They looked in 39 states. And out of many samples that they checked, about 60,000 samples, again, in primary care, 413 were positive for xylazine in adults between ages 20 and 73 years old. And they found samples positive in 25 of 39 states. So far more widespread than was suspected. And again, this was done in a primary care population, so not even specifically targeting a population of people who use drugs. They found that xylazine was mixed with many substances, most commonly fentanyl. And the conclusion from the study was really, one, it's under-recognized how prevalent its addition is to the unregulated drug supply throughout the United States. And really that our harm reduction should be targeted much broadly to the general population and include tips that I'll get to momentarily on, for example, how to address xylazine with individuals. So this is a study that was looking at individuals Sorry, let me just let that person in so it's not blocking my screen. So this was helping people more appropriately guide harm reduction responses to individuals in their communities of people using drugs. So again, what you see on the left-hand side, it's showing when xylazine or something else was identified in the sample, and then if it was found in combination with fentanyl. So more than anything else, you can see that xylazine was found alongside fentanyl. So again, our harm reduction should be appropriately targeting individuals for not just opioids, but for xylazine and other substances, particularly if they're known to be using other substances. And many people intentionally are co-using substances, but obviously there are some cases where individuals aren't aware of other substances in the substance they intended to use. So this is covering more about ethnographic research. So this was a very long study that was done between 2007 and 2021, so 14 years of data. So these folks embedded themselves into a majority Puerto Rican neighborhood in Philadelphia and lived in the community so that they could really learn about xylazine, people who used it, people who sold it, etc. And they compiled over 1,500 pages of field notes, hundreds of interviews, etc., in order to really understand qualitatively the population of individuals using xylazine. So there's some very interesting quotes within this study that was published. So this is the point of view of a person who's using drugs. I'm just going to read one of these quotes because they're quite long. But this was from Annie, who's a white 25-year-old woman who injects opioids and methamphetamine. I got some friends out there that got really torn up by it. They got holes in them, abscesses. Basically, it's like the body is rotting. People here are losing limbs like with gangrene. Whatever they're doing with the tranq, somebody is getting these scabby sores all over their bodies, and many of them don't shoot meth. So it's from the dope. You know what I mean? You have the dope, then the fentanyl, now it's the tranq-fent, the rhinoceros tranquilizer, the horse tranquilizer, cooked up and it's broken down and it's added to the dope, and we seek that out. You know what I mean? Our habits are fentanyl and tranquilizer. So again, referring to the wounds, and clearly wounds that went untreated. There was also some quotes from the harm reductionist point of view. And so I'm going to read the one on the right. So the number of people I was reversing, so administering naloxone to, was definitely going up. There were people who would become only minimally alert and only be slightly responsive to naloxone. So that definitely concerned us that something different was happening, that there were non-opioid agents involved. We did a lot of naloxone trainings. We had to focus more on the necessity of doing rescue breaths, not just giving naloxone. This is, again, epidemiological data out of Philadelphia, and this is between 2010 and 2019, and this is looking at the number and percentage of heroin and or fentanyl unintentional overdose deaths involving xylazine. So between 2010 and 2015, xylazine was in 2% of the overdose deaths involving heroin or fentanyl. It went up to 11% in 2016, was 10% in 2017, 18% in 2018, and 31% in 2019. This is looking at fentanyl co-detections among xylazine positive overdose decedents between 2015 and 2020. And you can see that starting in 2018, they detected xylazine and fentanyl 100% of the time. Again, this is reiterating that data that I shared with you previously about the majority of the supply of dope, meaning heroin or fentanyl in Philadelphia, also contains xylazine. So interestingly, as they saw xylazine increase in the drug supply in Philadelphia and involved in overdose deaths, they saw the role of benzos decreasing, and they pretty much converged right around the time of COVID-19 starting. This is epidemiological data out of Cook County, Illinois, so where Chicago is, between 2017 and 2021. On the left-hand side, it's showing the number of xylazine-involved deaths. So you can see that that really spiked up starting during COVID-19. And on the right-hand side, the percentage of fentanyl-involved deaths, same thing. You see a huge spike going up, starting continuously up around the time of COVID-19. So this was looking at xylazine as an emerging novel substance, or NPS, in overdose deaths in Connecticut in 2019 to 2020. So what they found here is that xylazine-associated deaths primarily occurred among males and non-Hispanic white persons, and the mortality was highest among people who are young, 25 to 34 years old. 57% of these deaths occurred at home, which was the predominant location of overdose. Based on the paraphernalia they found at the scene of the overdose, injection drug use was the most common route of administration. And then, as we've discussed, they found that most of these xylazine fentanyl deaths also included multiple other substances. So again, recognizing that polysubstance use is the norm and polysubstance overdose is the norm. This is again out of Connecticut, that data 2019 to 2021, recognizing xylazine as an emerging substance in the community and recognizing that, again, we needed more studies done on xylazine and we need to be doing more harm reduction education on xylazine. This is epidemiological data from the United States as a whole from 2019, looking at xylazine detection and involvement in drug overdose deaths. So they found xylazine to be present in 1.8% of all overdose deaths, again, in the United States as a whole. And it was listed as a cause of death in 64.3% of deaths in which it was detected. This is, again, an ethnographic study, so talking about the spread of xylazine across the U.S. So from 2015 to 2020, the percentage of all drug overdose deaths involving xylazine increased from 2 to 26% in Pennsylvania, 19% of drug overdose deaths in Maryland in 2021, and 10% in Connecticut in 2020. So this is again from that same study, looking at multiple geographical jurisdictions around the country. And this was a mixed method study, and it was looking at people who inject xylazine or use xylazine and people who sell xylazine. So they looked in 10 jurisdictions around the United States, and they found that xylazine was increasingly present in overdose deaths in all of those jurisdictions, so all census regions of the US. So illicitly manufactured fentanyl was present in 98.4% of xylazine present overdose deaths. So again, that strong ecological link that we're seeing over and over between fentanyl and xylazine. This is looking at a map of the US from that same study, looking at xylazine positivity. So where it is red is a higher percentage of xylazine positivity in overdose deaths, and followed by orange, a darker yellow, lighter yellow, green, and blue. And those jurisdictions, the squares are cities, the counties are the diamond shape, and states are circles. So you can see that that hotspot really is Maryland and Pennsylvania, primarily Philadelphia on this map. But again, we're seeing growing prevalence. This is showing that pattern again of how xylazine travels with fentanyl. So regardless of the geographical jurisdiction, you can see that fentanyl and xylazine were together 100% of the times. And then depending again on the jurisdiction, there was variability in what other substances were found in that supply. So sometimes heroin, methamphetamine, cocaine, designer benzos, etc. This is a very interesting study that came out of Maryland, and this was looking at the drug overdose deaths in the 2 counties with the most significant number of overdose deaths. So that was Baltimore City and Baltimore County. And so what they found was that 71% of the overdose deaths involved fentanyl, and the majority, 76% of those, were polysubstance overdose deaths. So they found 3 what they called latent classes of substance co-use. There was the fentanyl, heroin, cocaine group, the fentanyl alcohol group, and then the prescription drug group. So that included opioids, benzodiazepines, and antidepressants. And then they found demographic differences between those groups. So the fentanyl, heroin, cocaine group was significantly younger, less than 30, female and white, compared to the fentanyl alcohol group, but more male and non-white than the prescription drug group. So all of those differences were statistically significant between each of those groups. So again, it's important that we understand the patient populations that we're trying to do education and harm reduction with, because there are distinct differences between groups. This comes from a DEA intelligence report, and this is called The Growing Threat of Xylazine and Its Mixture with Illicit Drugs from October of 2022. So on the left-hand side is showing DEA forensic lab identifications of xylazine by region. So I think the most important is to look at the percent increase. So in the Northeast from 20 to 21, that increase went up. That percent increase was 61%. In the South, it was 193%. In the Midwest, 7%. And in the West, 112%. On the right-hand side, looking at number of xylazine positive overdose deaths by region, again, looking at percent increase from 2020 to 2021. In the Northeast, it was 103%. In the South, 1,127%, in the Midwest, 516%, and in the West, 750%. So this study looked trying to determine sort of what constitutes a potentially fatal level of xylazine. And I mean, to cut to the chase, we don't know that information yet. So this was looking at the prevalence of drug combinations at its xylazine specifically through forensic toxicology casework. So they looked at cases for 2.5 years from January of 2019 to June of 2021. They looked at driving under the influence of drugs and medical legal death investigations. They looked at over 170,000 cases, and 97% of the cases that screened positive for xylazine were medical legal death investigations as opposed to driving under the influence cases. So the two MDI cases that had very high concentrations of xylazine at 9,100 and 11,000 nanograms per milliliter were intentional drug overdose suicides, specifically with xylazine. So it had no opioids on board. But other than that, you found xylazine and fentanyl or a fentanyl analog hand in hand in the rest of those MDI or medical legal drug cases. And so again, we don't know. With those very high level, that was enough to cause a death, but there's a variability in the amount of xylazine that we see in other cases where xylazine may or may not have played a role in the death. So we still need more work done in that area. This comes from Dr. Gupta from ONDCP's listening session back in December in starting to talk to states about xylazine and come up with sort of a federal action plan around xylazine. So that led to a couple things that have happened since then. So there was the SAMHSA Dear Colleague letter on xylazine that came out at the end of March, which is again warning providers and communities about the presence of xylazine in the drug supply, particularly with fentanyl. Finally, on April 12th, the Biden-Harris administration designated fentanyl combined with xylazine as an emerging threat to the United States. So one, hopefully that'll increase awareness, but two, hopefully that will bring needed attention onto areas of research that are needed around xylazine. So an article came out that Dr. Gupta was one of the authors of in the New England Journal of Medicine on xylazine, medical and public health perspectives. It's a really nice overview. And here on the left-hand side is looking at estimated xylazine-involved drug poisoning deaths in the US 2018 to 2021. And then this is an example on the right-hand side of a xylazine-associated skin injury. So what about xylazine overdoses? Are they similar to overdoses that are due to clonidine? So first, just a little bit about clonidine overdoses. So they are a common source of both adult and pediatric overdoses. So in adults, it's usually in adults that have a concomitant substance use disorder and are being prescribed clonidine or are taking clonidine. And with children, it's often an accidental ingestion. And so how does it cause an overdose? Well, it leads to profound sedation sedation, similar to xylazine, but in clonidines case, it also leads to bradycardia and hypotension in overdose. So clonidine acts on two different receptors in the brain. So when we talked about pharmacology of xylazine, we talked about the central alpha-2 receptor, but clonidine also acts on imidazoline receptors, which are responsible for the bradycardia and hypotension in clonidine overdoses. The central alpha-2 receptor is what leads to the sedation in clonidine and xylazine overdoses. So here's that picture that I said I would share with you. So xylazine has no imidazoline receptor activity. So xylazine does not follow the upper pathway that leads to hypotension and bradycardia. Xylazine only follows the bottom pathway, which leads to central nervous system sedation. So a little bit more information about that forensic toxicology casework. So we talked about the 2 fatal xylazine intentional overdoses with those high levels, but they looked at many other cases in which xylazine was involved in the overdose death, and there was a huge range in concentrations, anywhere from 5 to 1,700 nanograms per milliliters. So we really don't know at what level xylazine will affect that individual user. And so there was one non-fatal attempted suicide case report, and their plasma concentration of xylazine was 4,600 nanograms per milliliter, and it did not cause an overdose, a fatal overdose. And so again, we could have pretty high concentrations of xylazine in an individual, and that xylazine overdose will not be fatal. But you have to treat them appropriately. So a little bit on xylazine overdose intervention and management. So we talked about the mechanism of action, that xylazine causes that airway occlusion, again, from that tongue relaxing against the back of the throat. So management in the field, what could that and what should that look like? You should always give naloxone in an overdose situation because, again, we have to treat the opioid component of the overdose. And since xylazine goes hand in hand with fentanyl, we want to be sure to treat that opioid component. So you want to give a dose of naloxone and activate EMS. Wait 2 full minutes before giving it a second dose of naloxone. If that individual does not respond to that second dose of naloxone, then you need to initiate additional breathing maneuvers. So you want to do head tilt, chin lift. You want to do rescue breathing. You want to put them in the recovery position, which is demonstrated at the top right-hand side. When EMS arrives, or if you have access to resources that EMS would have, then you could do a pulse oximetry. Is there oxygen level decreasing? Do airway monitoring and control. So do you have a bag valve mask, which is pictured on the right-hand side on the bottom? Do you have an oral airway that you could put in the individual's mouth, or a nasal airway that you could put down the individual's nose to help to move that tongue out of the way to free up that airway? Do you have the ability to administer oxygen? And again, some folks may need to be intubated or attached to a ventilator for additional breathing support. So there is not an antidote for xylazine that is approved for use in humans. There is a veterinary medication that is, but again, there's nothing right now that's approved in humans. So another thing that's been happening is sort of the myth of naloxone resistance. So naloxone is a very effective medication against opioids, but again, I think people are not recognizing the role of polysubstance overdose. So naloxone will only address the opioid component of the overdose. It will not have a clinical effect on other components of the overdose. So we talked about giving naloxone first because, again, xylazine and fentanyl travel together. But when we hear about people needing 5, 6, 7 doses of naloxone, that is not supported by the literature. Those are anecdotal reports. And I think, again, it's because people are not recognizing polysubstance overdose. So you don't want to just keep pumping someone full of naloxone because it's not benign. It causes severe precipitated opioid withdrawal in individuals who are given large doses of naloxone. So you want to give the 2 doses of naloxone, and then you want to do those additional airway maneuvers. So just a reminder, what is the indication for use of naloxone? Apnea or cyanosis and decreased mental status in a suspected opioid overdose. So a respiratory rate of less than 8 breaths per minute, or a pulse ox that's less than 92% or decreasing. So we don't want to give somebody naloxone who is breathing, and we don't need to continue to give naloxone until somebody is walking and talking. We just want to normalize breathing. So what is the difference between someone being high and someone experiencing an overdose? So an acute intoxication, or someone who's high, they usually have relaxed muscles. They have a normal skin tone. They may have slowed or slurred speech. They usually will have a drowsy appearance, depending on, again, if they're using other substances. They're responsive to stimuli. And again, depending on what substances they use, they usually will have a normal heart rate. We should not be giving naloxone to people who are high. We should only be using naloxone in an overdose situation. So what does an overdose look like? The person will have a bluish color of their skin, lips, or nail beds, depending on their baseline skin tone. They are unconscious. They are not responsive. They may have a slowed heart rate, again, depending on substances that they're using, and they would have slowed or no respirations. So just reminders and steps to respond to an overdose. You try to wake the person up, ask if they're okay, introduce yourself, do a sternal rub, so rub across the front of their chest. Ask for consent before attempting to help, even if they're unconscious. If they verbally refuse help, then they are not in an overdose. Doesn't mean they might not be in a little while, but they are not. And there's implied consent if the person is unresponsive. So you want to call 911, put the phone on the ground, give the location, describe the symptoms. So somebody is unconscious, and then clear the area in case you need to do other maneuvers like rescue breathing or even CPR. So you want to administer naloxone, wait that 2 full minutes between naloxone doses, give the naloxone a chance to work. And then remember, rescue breathing may be necessary. So either in an opioid only overdose or in a polysubstance overdose. So you want to clear the airway, do a tilt the head back and lift the chin, pinch the nose, give 2 quick breaths, wait 5 seconds, and then give 1 breath every 5 seconds. If there is no pulse, you do want to give chest compressions. And if you know how to do full CPR, do full CPR. The individual should be put in the rescue or recovery position if you've given naloxone and, for example, their breathing has improved, but they're still unconscious. Put them in the recovery position. If you have to leave the scene momentarily, put them in the recovery position. So again, if they vomit, they don't aspirate. That also may move the tongue from the position where it's blocking the airway. So here's a nice little patient handout that came out. This is on how to stay safer with Xylazine. It just gives quick tips that I just covered. So we talked about consider use of a pulse ox. So again, this measures the amount of oxygen in the blood. It can be a helpful tool for determining if someone's overdosing or heavily sedated. So normal saturation should be in the 90s, but if somebody is lower than 90% or steadily decreasing, that would be a concern, and you would want to then be sure that you're helping to normalize their breathing. And at 70%, there's no oxygen getting to the brain. This is a very detailed slide. I'm not going to go into this, but this talks about the use of an ambu bag or a bag valve mask, again, as another tool to help normalize breathing. This talks about nasal or oral airways, again, another tool to help move the tongue out of the way if it's blocking an individual's airway. So what could you anticipate in the context of a xylazine overdose? So what are some possible clinical findings? There could be, depending on what co-use of other substances, blood pressure, heart rate instability, heavy sedation, unconsciousness or coma, respiratory depression or arrest, hyperglycemia under the influence of xylazine, followed by rebound hypoglycemia. There could be cardiac arrhythmias, meiosis or small pupils, hyporeflexia, central nervous system depression, and even enuresis or urinary incontinence. What are some supportive care considerations for a person with a xylazine overdose? Avoid any CNS depressions like benzodiazepines, etc. Give oxygen. You might need to give IV fluids. Consider IV atropine, but there's no clear data to support that. Ventilator assistance or intubation may be necessary. IV insulin may be needed if the person is hyperglycemic. perhaps ECG continuous monitoring, pulse oximetry continuous monitoring. Depending on how long they've been stationary in a position, they may need electrolyte replenishment, and dialysis is not effective, similar to fentanyl, because of the lipophilicity of xylazine. What is some ongoing monitoring with individuals with prolonged sedation due to a xylazine overdose? So we talked about that people could be unconscious for many hours, so they should be repositioned every 2 hours. So you want to roll them to the opposite side, smooth out the skin, massage or rub areas that may appear red or swollen. Try to keep the skin as clean as possible and flex or bend the joints. When the individual awakens, you want to exercise the limbs, again, to prevent blood clots or DVTs, and monitor for signs of a DVT, so redness, swelling, or pain in a lower extremity or foot on one limb only. What about diagnostic testing for xylazine? So there aren't yet commercially available point-of-care tests or really standardization in clinic settings or hospital settings. There's not a urine immunoassay for xylazine. There are xylazine test strips. They are now commercially available. That just happened in the last month or so. They have been studied, and they have had validated testing done, and I'll go over that validation testing in just a moment. Xylazine is eliminated rapidly from the body, so its half-life is 23 to 50 minutes. 70% is excreted in the urine, and its major metabolite is 2,6-xylidine. It can be detected in both serum and urine, but usually it requires more sophisticated techniques, drug checking techniques, which I've listed there, and that requires a longer turnaround time. So that's really more for surveillance than for point of care drug checking with individuals who use drugs. This was a study that was looking on if using xylazine test strips would be acceptable to people who use drugs. So they did qualitative interviews with individuals who had used fentanyl test strips before. And what they found is that individuals were interested in using xylazine test strips when and if they became available. Most of these individuals reported not wanting to use opioids that had a xylazine added to them. They did not like the way they made them felt. So again, showing clear preferences for different substances in co-use. So this was a tweet that came out way before xylazine test strips came available. This was from November of 2022, stating that BTNX out of Canada had a xylazine test strip, but they just became available last month. This is information about the validation testing that was done for xylazine test strips. So the main message here is that drug samples that contained xylazine were detected appropriately with the xylazine test strips, and samples that did not test xylazine appropriately tested negative on the test strips. Similar to fentanyl test strips, there are samples that you may have to use a different dilution method because they may cause false positives. So that could include stimulants, and particularly if it has the presence of lidocaine. So again, we will know more information as more people use xylazine test strips and we get more information back. What we've heard from our New York City partners is that they are extremely sensitive, and so they pick up xylazine at very low levels, including less than 5%. So most point of care FTR drug checking in New York City has a threshold of 5%. So the FTR would test negative for xylazine and the test strip would test positive. And again, that's not clinically significant. So it's important when we think about using xylazine test strips with individuals that we think about doing appropriate education and targeting individuals specifically using fentanyl to give xylazine test strips. So this was a validation study specifically for BTNX test strips. And again, they found a high sensitivity, 100%. So they're very, very sensitive at picking up xylazine. Specificity was 85% and precision was 91%. And again, they identified lidocaine as causing false positive results. I'm going to move into skin ulcers or wounds in xylazine. So this is data again out of Philadelphia showing the number of hospitalizations for skin and soft tissue infections associated with substance use from 2010 to 2019. And you can see that significant increase over time that correlates with the increase of xylazine in the drug supply. So just a reminder that these can develop into severe necrotic skin ulcerations, needing complicated wound care if not recognized early. So they can occur at sites of injection, they can occur at sites not associated with injection, and they can occur in individuals who don't inject. So we really do not understand yet the pathophysiological mechanism which causes the ulcerations to occur. As I mentioned very early in the talk, they are not infectious, but they can become super infected with bacteria. So really important that people don't skin pick. So just a trigger warning that there's some graphic photos on the next slide. So these show what can happen if somebody's wound is not appropriately treated. And it doesn't need to get like this. There are interventions that can be done, but it's important that healthcare personnel, particularly EMS and emergency department clinicians, are recognizing wounds early and giving appropriate treatment. So on the bottom right-hand corner is showing you what the wounds look like initially, and that's when it's important to do early management. So keeping the wound moist, the temperature consistent, and keeping it wrapped. So xyloform dressing is the preferred dressing. So this is just reminding us that we have many potential causes of wounds from injection drug use. And here it's really the effect of the substance. So similar to levimazole causing wounds, as does xylazine. There are many mechanisms of action for wounds to be caused by injection drug use, but this actually seems to be caused by the substance itself. I included some information on safer injecting practices, which again should be information shared with individuals who are injecting. I just included it here for completion. So here's some information on xylazine wound care management. Since I submitted these slides, there's actually been more information that's come out. There have been a couple of really good webinars that have been held on xylazine wound care. So I would be happy to talk about that more next week on the Q&A. So main thing, if people can cut back or seek out a supply without xylazine, that would be the best if they could do that. But again, they may experience a xylazine withdrawal syndrome if they stop using xylazine rapidly. So it's important to treat that appropriately, which we'll get into in a few minutes. Advise people not to skin pick. Debriding may need to happen if a wound gets like some of the ones on the prior page with some of that dead skin. We talked about keeping the wound clean and moist. There are a variety of ways you can do that. Meta honey is pictured here, so that's medical grade honey, but you could also use Vaseline and plain old soap and water is fine as well. If the wound develops those more severe effects, or it becomes secondarily infected, obviously you would need to add other agents on top of that. And then often these wounds weep, so you want to include an absorbent pad in addition to the xyloform wrap. So I just included this again for completeness, some information on the role of honey in wound healing. It has many antibacterial and pro-immunological properties to it, so it does help with healing. So what about the xylazine withdrawal syndrome? So it is not yet well characterized. The primary symptom is anxiety. There aren't really any severe vital sign abnormalities associated specifically with xylazine, and there aren't any associated withdrawal seizures. The duration of the symptoms typically is several days to several weeks, but they may have protracted symptoms. So it is similar with clonidine withdrawal, for example, and I've listed some of the symptoms there. It can really look a lot like opioid withdrawal syndrome. So if you're treating someone for what you think is opioid withdrawal syndrome and they're not responding appropriately, or you're trying to initiate them on medication for opioid use disorder and it's not going as predicted, you want to be sure to ask somebody if they're using xylazine or treat for xylazine withdrawal syndrome. You want to think about that in that picture. So again, we have a little bit more information than when I created these slides. There's a document that's come out of University of Pennsylvania on how to treat xylazine withdrawal management. This was some information that came out of the Philadelphia Department of Health. We don't have firm best practices yet, but we have a little bit more information than we did a few months ago. So clonidine is really the first line agent in treating xylazine withdrawal, but you can also use other agents such as gabapentin, for instance. Sometimes people may have additional other symptoms that also need to be treated that may be treated well with ketamine or an antipsychotic or a variety of other medications. This is the only case that's been published thus far about xylazine withdrawal in a hospitalized patient. So this was an individual who had been admitted for treatment of the xylazine wounds that are in the picture and had left AMA from several hospitalizations because her xylazine withdrawal was not being recognized or treated appropriately. So in this individual, what they ended up doing was admitting her to the ICU for treatment of her wounds. And then they managed her xylazine withdrawal with a combination of dexmedetomidine infusion, phenobarbital, and tizanidine, and then transitioned her to clonidine. So by hospital day 4, she was no longer experiencing withdrawal symptoms, and she transitioned to full agonist opioids for pain initially, and then eventually to buprenorphine, and they had to do a low-dose buprenorphine initiation strategy, and she was ultimately discharged on day 19 on buprenorphine, clonidine, and gabapentin. So again, successful management of a patient with both xylazine and opioid withdrawal. So I included this again for completeness. I'm not going to go into this, but dexmedetomidine infusion is a potential treatment for severe xylazine withdrawal. So moving towards our conclusion, so what are the big factors known with respect to xylazine? So we know that it's being added intentionally to the unregulated drug supply, particularly with fentanyl. There's that strong ecological link, likely to increase the duration of fentanyl's effects. It's associated with skin ulcers and wounds, and it's found increasingly in the unregulated drug supply in the US. It's definitely entrenched in the Northeast, but again, the prevalence is under-recognized because it's not a standard part of toxicologies in, say, an SUD treatment setting, and it's also not standard in post-mortem toxicology in most jurisdictions. We also know that it's associated with heavy sedation and overdose, and it's likely highly under-recognized in most overdose situations, non-responsive to naloxone because it's not an opioid, and often, unfortunately, naloxone is often the standard and only response in most overdose situations. So what are the big unknown factors with respect to xylazine? Its actual prevalence in the unregulated drug supply outside of certain jurisdictions that we have good information on, such as Maryland, Pennsylvania, New York, and Connecticut. So it isn't a part of point of care testing or quantitative toxicology testing. Even if it's detected on postmortem testing, there's no standardization, so it's not necessarily included routinely on the death certificate. And comprehensive surveillance drug checking for communities or point of care drug checking for people who use drugs are not available in most settings. We need additional comparative ethnographic experiences outside of Philadelphia and Puerto Rico, where all of our ethnographic data is from so far. We need more information on how the concentration of xylazine affects the subjective use experience and also the risk of overdose. We need to better understand the mechanism of action for skin ulcers and wounds and best practices for wound care management. We need to understand best practices for xylazine use disorder management, as well as xylazine withdrawal management. And we really don't know where in the supply chain that xylazine is added, so we need more information on that. So another topic that comes up is, why are people advocating for a safe or safer drug supply, and what does that mean? So this is from an article that came out of Canada. So in parts of Canada, there is a safer drug supply. So people, for example, who fail treatment with the 3 well-known approved medications for the treatment of opioid use disorder, methadone, and buprenorphine being first-tier medications, naltrexone being a second-tier medication, then individuals in Canada are provided with either injectable heroin or injectable hydromorphone tablets to treat their opioid use disorder, so that, again, they're not at risk of overdose by using from the unregulated drug supply. So what would a safer supply mean for people who use drugs? So it would mean fewer overdose deaths, and it would mean that we would not have such an unpredictable drug supply that has many complications that are often not recognized or recognized too late and lead to poor outcomes for people who use drugs. So many of the issues that we encounter currently with the unregulated drug supply would be eliminated with a safer supply. Now, in the United States, the concept of a safer drug supply is very controversial because of the stigma that we associate with substance use. But in Canada and Europe, this is not controversial. So how has xylazine being in the unregulated drug supply, how has that affected drug user communities or harm reduction communities and syringe service programs? So obviously that's had a huge impact because of the increased overdoses, the high death rates associated with overdoses, the bad experiences that xylazine can have for people who use drugs. And it creates more stigma towards people who use drugs with, again, creating drug panic around xylazine. So it's really challenging for these communities to address, yet another new substance in the drug supply. The other thing is when we think about our overdose response, we really could take a lesson from overdose prevention centers or supervised consumption spaces worldwide. So this was an article that came out of Canada. And again, when we look at data worldwide, there has never been an fatal overdose in any overdose prevention center or safe consumption space anywhere in the world, ever. So clearly they have a very nuanced response to overdose, and we could learn a lot from what their experiences are in reversing overdoses in those settings. So again, xylazine awareness is key. So many people who use drugs report that often their provider didn't know what xylazine was or had never heard of it. And then another thing is that often people who use drugs perceive that their xylazine withdrawal is not being recognized or treated. So particularly in inpatient settings, and that could be inpatient rehab settings for substance use disorder, or it could be a hospitalization for an admission for another reason, like treating wounds. But people are certainly less likely to stay in care if there are not addressed, all their symptoms aren't addressed, including their xylazine withdrawal. So these negative patient experiences, unfortunately, lead to worse outcomes and more complicated care for people who use drugs. And then again, just always think outside the box. And when you're faced with an overdose, think polysubstance overdose and utilize the maneuvers that we talked about. So just to pull everything together for my conclusions, so xylazine's prevalence is likely underreported both in its geographic distribution and in its contribution to overdose deaths. Again, there's no routinization of xylazine's inclusion in toxicology testing. So xylazine test strips are now available and have undergone validation testing, and they are available commercially. So that is something to think about utilizing in your interactions with individuals using fentanyl. So there's limited research on xylazine overall. So that means that how to treat xylazine use disorder, what are the physiological effects of xylazine with both acute and chronic use, we don't really know. And what are the best practices for the treatment of xylazine withdrawal and xylazine skin ulcers and wounds? We're starting to get some information, but we don't yet have solid best practices, so more research is needed. Xylazine use and withdrawal is under-recognized by treatment providers, and obviously this leads to poor outcomes for people who use drugs with respect to many factors along the continuum of care, so engagement in care, adherence with care, and initiation on MOUD and other treatments. Polysubstance overdoses are under-recognized, and xylazine's presence in the unregulated drug supply complicates overdoses and requires a more nuanced response to overdoses. Naloxone will not reverse the xylazine component of the overdose, so rescue breathing, pulse oximetry, administration of oxygen, and airway management should be part of the algorithm to respond to polysubstance overdose. And again, we're going to do questions. I mean, I have a couple minutes, John, if anybody wants to ask burning questions before next week. And I included my email, so you can always email me with questions, and I'll put my email in the chat.
Kelly, what are your thoughts on testing the water supply similar to we did in COVID to just kind of alert our local area to the presence of xylazine or frequency or just kind of the prevalence of use?
So I know a lot of jurisdictions do that. I mean, it can be informative for just kind of assessing globally how prevalent it is. I think I probably would, and again, I don't know what the laws are in Kentucky, so I can only speak from my New York lens. So in New York, what we're doing to figure out the prevalence is we're actually the New York State Department of Health, my agency, and the New York City Department of Health and Mental Hygiene. We're all doing drug checking projects so we can get a better sense of the prevalence around the state. So we're doing it, each of us is doing it a little bit differently. Our project is going to be solely point of care. So it's going to be embedded at harm reduction programs and outreach and engagement providers, so street outreach providers, and people can bring their substances to be checked. And so we'll be able to get a sense around the state based on point of care testing, how prevalent it is. And New York City is doing a combination of point of care and surveillance drug checking. So they're doing a point of care at the OPCs in New York City, the 2 overdose prevention centers in New York City, as well as some harm reduction programs. But they're also sending more samples off to a lab just to, again, do surveillance. That's not informative for the individual at the time of use. And then New York State Department of Health at its 12 drug user health hubs and all the harm reduction programs around the state is also doing drug checking surveillance. So in other words, finding that out. So I think, Matt, it depends on what the resources are available in the state. So if you guys are not doing drug checking to assess surveillance and in the state, and if you're not doing routine postmortem checking so that you can see what contributions xylazine is having to overdoses, like all in New York City, all overdose deaths, xylazine testing is part of the testing. So we have a really good sense, but we don't in the rest of the state. So I think it just depends on what your state is willing to do that. So if none of those options that I said are a possibility, then certainly you could do wastewater testing. It'll give you a sense of what's going on.